Good evening, everyone. We are very happy to have you with us. My name is Mahmoud Salah. I am the Chief of Vascular Surgery in the Saudi German Hospitals Group. Today I am honored to chair this session. We have our honorable speaker, Professor Martin Stork. Professor Martin is the director of the Department of Vascular and Thoracic Surgery in Karlsruhe, which is the academic teaching hospital for University of Freiburg, Germany. Welcome, Dr. Martin. And we have our panelists. We have Dr. Ala Ahmed. He is a consultant vascular surgeon in the Saudi German Hospital, Jeddah. And we have Dr. Muhammad Rafat. He's a consultant vascular surgeon in Saudi German Hospital, Dubai. We are missing one of our friends, the panelist, Dr. Ayman. He is obviously is not able to come. So we will start our presentation. We'll have two presentations. Dr. Martin will give the first one, and I'll give the second one. Dr. Martin will talk about current concepts for treatment of extracranial carotid stenosis. Dr. Martin, please, the screen is yours.
Thank you very much. I hope you can hear me and see the screen, my screen. Can everybody see it? I would like to thank Dr. Mahmoud for inviting me to give a presentation for this honorable audience. It's a few years ago that I visited the Saudi German hospital for the first time, and I was really impressed about the quality of vascular surgery there and in the Saudi German hospital group. I was asked to talk about, we agreed to talk about surgical treatment actually, and endovascular treatment also of extracranial carotid stenosis. And I hope you can see my screen. Can you see it? This next slide. There is no potential conflict of interest, so I do not own any company or any stock. The surgery for carotid artery stenosis still needed. This is a question some interventionalists ask over and over, especially at medical congresses, because of course endovascular treatment of vascular disease is very broadly accepted. But the carotid artery is a little bit an exception, because in this particular field of surgery in any randomized trial, of course there are special centers maybe where the results are just as good. And during my talk I would like to show you some large registry data also from the US that this is still a little problem, and that's why surgery is still very effective and needed. And you can see it's also not very invasive. It's a very small incision, and in our hospital we do most of the cases in regional anesthesia. Actually, it has a very long tradition. The first carotid endarterectomy was already performed in 1953, so that's one of the oldest surgical procedures in vascular surgery. Even before the subject of vascular surgery as a own specialty was founded, was done by Michael DeBakey in Houston, and the second by Eastcott. And Eastcott performed it the way we do today, with opening up and closing it with a patch suture. Since then, many trials have been undertaken, and it's one of the best investigated procedures for prophylaxis of stroke. So what we actually want to do is we want to prevent stroke, and this is why asymptomatic stenosis is treated, and especially symptomatic stenosis, because in symptomatic stenosis, and these cases were symptomatic, the first cases, it's already embolizing plaque, and we are afraid of a large stroke if this is not treated. And if you now think about why surgery and why not stenting, and of course there are certain clinical conditions where surgery has to be considered in first place without any debate. And one of the things is, and for time reasons I cannot go too much into details, maybe at some other meeting, but if there's a very severe kinking of the artery, or even very severe circular calcification, the stent angioplasty of the carotid artery is not very easy to do and might leave some problems behind. Also, we have the new aspect of access to the carotid artery from the aortic arch, which is not an issue in surgery, but of course for endovascular surgery. And then we have these emergency cases like floating thrombus in the carotid artery. This should not be done by interventional and lysis. For best treatment is surgery, maybe in combination with endovascular treatment. And some special indication is the incoming stroke, where we can prevent a large stroke if the patient is still awake. And of course, there are some other special conditions. This is a very special condition because here you see a complete occlusion of the common carotid artery. And this patient was sent to us with the question, could we do a vascular reconstruction? So I start with a very special case, which is not typical. This was a male patient, 57 years old, with dizziness, and he had a small posterior infarction, but ranking 1 in the modified ranking scale 3 months earlier. And we discussed it a lot of times, and we decided for conservative treatment because he was very well collateralized in the intracranial circulation. So in this case, we need to do an MR angiogram to really judge the circulus villicii up here and how much the other side can contribute to both sides, because there are some anatomical variations here. So this is actually the region of interest for deciding whether or not to do conservative treatment. This is now routine in our hospital. Dr. Mahmoud visited our hospital, and I think it's possible to do it very well in regional anesthesia. If you do you need to really block this cervical plexus, a superficial plexus block with ultrasound guidance, and then you can, the patient is under heavy sedation, but he's still awake, to move his hand, and then we open the carotid with or without shunt, and the decision about shunt can be done with awake monitoring. And then we do some quality control with flow measurement, angiogram, and you saw this already, a rather small incision. The neuromonitoring is necessary if you do patient in general anesthesia, because you have no way to judge the extent of clamping ischemia. And you can see here very fast, 1 minute after clamping, this curve becomes flattened. If you put a shunt in, it will open again. If you close the shunt, it will be flattened again. And if you declamp, it will return to normal. And there are also other methods like the near-infrared spectroscopy, which is also an alternative. It's just 2 electrodes on the forehead, but it's not as exact as this. This advantage of this is it reacts very fast. Yes, so why do we treat carotid surgery, symptomatic carotid stenosis? And we do have good evidence, and I think Dr. Mahmoud will also show in the guideline recommendations the evidence actually summarized. But this is the 5-year accumulation risk of ipsilateral stroke in 2 large studies in symptomatic stenosis, and you can really see in this Cochrane analysis, and this is a very accepted way of doing a meta-analysis, that there is a big advantage of surgery versus conservative treatment. So I think the issue that we have to do something about the symptomatic carotid artery is already scientifically decided. So we should not send a patient with a transitory ischemic attack away or put him on conservative treatment, especially if the stenosis is higher than 70%. So the risk reduction is only really working in the high-grade stenosis. So that's a little bit difficult to understand, but if the carotid stenosis is only 50% or less, then surgery or interventional treatment is not effective in stroke prevention as in the high-grade stenosis. And if it's near occlusion, almost occluded, then it becomes less evident. I think Dr. Mahmoud will show you this in his presentation or similar slides. The problem is that in asymptomatic stenosis, the evidence is not as convincing, but only because the trials are not finished yet. The ACS2 trial is really in asymptomatic patients, more than 3,500 patients randomized for surgery and stenting, and we have to wait until these studies are finished to have here class 1 evidence. At the moment, we do only have class 2 evidence, but in high-grade stenosis, especially if it's 60 to 99% following nastic criteria, it's a good option to do surgery or stenting instead of only conservative treatment. Now, coming back to stenting, and I know that stenting is very popular also in the Middle East area and in many regions of the world, like the United States. So the CREST-2 CAS registry. It's a registry about the quality of stenting, and this is very interesting to really see how the stroke rates are. So this is 187 interventionalists from 98 sites in the United States, so good experts. If they treat asymptomatic stenosis, they have still a rate of stroke and death of 1.4%, and if it's symptomatic, the stroke and death rate even higher. And this is for stenting. In other words, the stenting is really not much better than surgery, even in this registry, and even if there are selected cases. This is not a randomized trial, it's but very recent data from the CREST-2 registry, and they have to be taken into consideration if you say the stent has less risk than surgery, which is not the case. Also, it's a little bit paradox, but the older the patient is, the more he profits from surgery. It means stenting becomes more dangerous the older the patient is. That has to do with the general condition of the vascular tissue in the aortic arch and the carotid wall. And this is a meta-analysis from 5 studies which were done. And you can see here the age-dependent difference in outcomes. These are younger patients. The older patients have a higher incidence of reaching the primary endpoint of stroke and death, 4 studies. And here you see this is not the case in the case of surgery. So again, this is in CAS, there is an age-dependent difference in outcome, and this is not seen in surgery. So it means older patients should not be prevented from surgery. This is the message of this meta-analysis. Also, in the United States, they have a recent publication of carotid and atherectomy octogenarians. This means patients more over 80 years. They can be treated with a reasonable low rate of stroke and death, as you can see here. If you compare octogenarians to younger patients, there is no statistical difference in stroke and death. Of course, mortality is always higher in older patients, but this is true for any surgery. So this is why I did not include this in this graph here. So what we need is an appropriate selection of patients who really benefit from surgery if they have a life expectancy of at least 2 years. Interestingly, in Europe, there's a huge difference in the indication. So you see green is okay indication, symptomatic high grade. Yellow is almost as effective. It's like asymptomatic, 50%, and red is bad indication. That means low grade stenosis, prophylactic indications, not even high grade. And you see some countries have more of the red bars than others. And you see Denmark, it's a small country in Europe, but they don't treat any asymptomatic stenosis, but we don't know what happens to these patients because there's no registry. So I think like Austria is doing quite okay. So if you have this, so we need these registry data to really know. Also, the absolute number of stents, this is from the German National Registry, which I'm in the council, you see 25,000 procedures per year in surgery compared to 6,000 in stenting. That means number of stenting, even if it's very popular, is not really increasing. This has to do with the neurologist, the patient information, because the stenting is still considered a little bit risky procedure in the carotid. And so we do not reach more than 19 or 20% of patients if we decide which treatment is done. And in other regions, this is from Canada, publication from Stroke, you see in the asymptomatic patients, the indication for surgery on a broad scale is really going down a little bit, and in the stenting there is not even a difference. So this is just to show you, careful with the asymptomatic, only high-grade stenosis or progressive stenosis, it might be like 10 to 20% of all cases. For the symptomatic, it's very typical. And this is just to show you, there's even a worldwide analysis showing the distribution of stenting and the outcome of surgery and stenting in different cases. Here you see Asia and Africa. Here it's very interesting that the stenting is not better than surgery, no matter in which area of the world it is performed. So this is one of the messages, that we still need surgery as a really effective procedure for patients with symptomatic carotid stenosis and also with high-grade asymptomatic stenosis in selected cases. In the end of my presentation, we decided to give 2 15-minute presentations, so I'm already coming in towards the end. There is this new hybrid technique which I would like to show you, probably know about it. This is a very small incision here on the common carotid artery and a special sheath introduced into the carotid. This can also be done in regional anesthesia. If you start to do this, both centers start with general anesthesia, and you have the flow reversal. The flow reversal means that the blood is drawn back here into this line and put back into the vein, and this imitates the proximal occlusion technique of the MoMA stent, for instance. And here you can also judge the speed of this. Here you see a detail of the sheath. And the number of this procedure after 26 in the United States is really going up and almost reaching the number of transfemoral carotid artery stenting. So there's a lot of propagation to do this. Also, this is done by vascular surgeons. This is something a surgeon is involved because they need this cut down. And so this is why Mark Shermer, his vascular surgeon, published this. And here you see the results. The patients treated with a TCAR have less strokes, or at least not higher stroke rates than the transfemoral carotid artery stenting. So that means the principle of flow reversal can be used in all patients if you do this TCAR procedure. So this is very interesting. We personally haven't started yet. I think in Germany it's 1 or 2 centers starting this, but this might be something in the future that might be replacing a little bit open surgery, but it's still too early to really judge this issue completely. So in summary, I would like to give you a take-home message. That means the quality of stenting seems to have reached a limit. That means cannot be further improved. We have seen the CREST-2 registry showing that the complication rates are still at 2% for symptomatic stenosis and not less than for surgery, which has to do with the disease rather than with the technique. And both techniques have comparable long-term results, but there are certain conditions where surgery is of advantage. I showed you the kinking, the calcification, the thrombus in the artery, and other, and also the incoming stroke and acute stroke surgery. And also what I would like to mention is the indication for surgery is very well evidence-based and has actually better evidence than the stenting, and that's why we still think we need skilled vascular surgeons who can do this procedure in the future, and the patients should be informed properly about these techniques and not be afraid. Also the neurologists should not be afraid to send patients to vascular surgeons for treating this disease. I thank you very much.
Thank you very much, Dr. Martin, for this very nice presentation. For the sake of time, I'll go to my presentation, and then we can have comments or questions. Okay. Dr. Martin spoke about the asymptomatic cases and the prophylaxis and treatment. I'll limit my talk to the guidelines, the latest guidelines in treatment and prophylaxis of the symptomatic patients. So I'm going to talk only about prevention in recently symptomatic patients, and these are the European Society of Vascular Surgeon guidelines in last year. Concerning the conservative treatment, of course, they are recommending antiplatelet therapy is recommended in symptomatic patients. And if aspirin or clopidogrel is not tolerant, we can use dipyridamole. And this is level 1A. This is very high level of evidence. All the patients undergoing carotid endarterectomy should receive antiplatelet therapy. But the long-term aspirin plus clopidogrel is not recommended in patients undergoing carotid endarterectomy. And all patients start statin should continue on statin. These are level 1B and level 3C. Indication for intervention, when to intervene in symptomatic patients who has symptoms in the last 6 months. If they have 70 to 99% carotid endarterectomy is recommended. And this is class 1A. This is very high level of evidence. If the stenosis is 50 to 69%, carotid endarterectomy should be considered. Okay, and these are also level 2A. Okay, how about patients with less than 50% stenosis? These can benefit from the surgery? Yes. Carotid intervention may be considered in recently symptomatic patients with less than 50% stenosis if they suffer recurrent symptoms despite the medical treatment. And this is level 2B. Okay. For total occlusion, for chronic internal carotid near total occlusion, carotid endarterectomy is not recommended, okay, unless they are still associated with recurrent ipsilateral symptoms, okay? So it will be indicated in these cases. This is level 3C. Timing of intervention, when to intervene. It's recommended as soon as possible. They say within 14 days of the symptoms. And if the patient is having symptoms in the preceding 14 days, carotid endarterectomy is recommended more than the carotid stenting. Okay, how about for neurologically unstable patients? Revascularization is not recommended in patients with 50 to 99% stenosis who are really unstable, suffering of disabling stroke. The area of infarction is more than 1/3 of the territory, not conscious or altered conscious and hemodynamically unstable. This is not recommended to do anything for these patients, but it's recommended if they have a stroke in evolution or TIA's crescendo. They are considered for urgent carotid endarterectomy, preferably in less than 24 hours. And this is class 2AC. Okay, carotid intervention after intravenous thrombolysis, to do it or not. Actually, carotid endarterectomy can be considered after intravenous thrombolysis only if there is a rapid neurological recovery, the area of infarction is less than 1/3, the previously occluded middle cerebral artery became recanalized, or if there is no evidence of hemorrhage or severe edema. Carotid intervention after intravenous thrombolysis, the optimal timing for intervention remains unknown, but better to be again early carotid endarterectomy within 14 days. And antiplatelets and heparin should be withheld for 24 hours after cessation of the thrombolysis. To give general anesthesia or locomotor anesthesia, Dr. Martin mentioned that he is using, or in his hospital they are using the locomotor anesthesia, yet the recommendation left this to the surgical team. They left the choice of anesthesia to the team. Okay, transverse or longitudinal. The transverse is more cosmetic and the longitudinal has better exposure, yet the recommendation said that we can use whichever incision the surgeon prefers. To go antegrade versus retrojugular exposure, again, this was left to the surgeon choice. To do carotid sinus nerve blockage during operation, actually it's not recommended to do it routinely for every patient because there is no evidence that it reduces the prevalence of hypo or hypertension or arrhythmia. So you can choose whatever you like, or you can use it selective, but they are not recommending to use it as routine. Anticoagulation and the protamine reversal, yes, they are recommending protamine reversal for heparin to prevent neck hematoma. Shunting, to use shunting as a routine or never to use shunting or to use it selective, the recommendation is very clear. you can use whatever you are trained for. It's recommended that the choice of shunting is left to the discretion of the operating surgeon. It depends on the surgeon training. Some are using it routine, some are using selective, some are not using. Carotid patching, this is very important. Routine patching is recommended. Routine patching was associated with significant reduction of the perioperative stroke, significant reduction of the 30 days internal carotid artery thrombosis, and there was randomized trial about patients who had primary closure and patients who had patches, and the patients with the primary closure showed that they were 3 times more likely to return to the theater within 30 days. So it's recommended. Last point about the patch type, any type did not affect the early outcome. So you can use whatever you are trained and familiar with. So routine patching is recommended rather than primary closure at all. And this is level evidence 1A, the highest level of evidence. Okay, to do eversion technique or traditional endarterectomy, the choice between eversion and patched endarterectomy should be left to the surgeon. They are giving more or less equal results. But the eversion is definitely recommended over the routine primary arteriotomy. Primary arteriotomy is less than the patched arteriotomy and the patched and the eversion technique. Carotid artery stenting, the use of embolic protection device should be considered in patients with undergoing cath, except they are not recommended if there is advanced common carotid disease, if there is external carotid artery disease, if the contralateral occlusion with insufficient collateralization, they are not recommending the embolic protection. Wound hematoma, you should not wait. Wound hematoma after carotid endarterectomy should be re-explored immediately, and this is level of evidence 1C. Restenosis after carotid intervention. Number one, we should know that recurrent lesion within 4 to 6 weeks is not restenosis. This is residual atherosclerosis. So this is not considered restenosis. This is considered residual atherosclerosis. And restenosis that occurs 3 to 6 months post-op, this is a real restenosis because this secondary to new intimal hyperplasia. But restenosis that occurs after 2 years, 24 months, these are not restenosis, these are recurrent atherosclerosis. So patient suffering of late ipsilateral stroke in the presence of, if the stenosis is 50 to 99% restenosis, should undergo redo carotid intervention. This is level of evidence 1A, the highest level of evidence. If the restenosis is less than 50%, should be treated medically. So the restenosis should be 50 to 99%. If in asymptomatic patient with 70 to 99% restenosis and still asymptomatic, if they are following carotid endarterectomy, re-intervention may be considered. If they are following carotid artery stenting, medical treatment is recommended. Okay, the problem of coronary and carotid artery disease. Routine screening for carotid disease prior to open heart surgery is not recommended. This is level of evidence 3C. Only if the patient is more than 70 years, if there is history of transient ischemic attacks or stroke, if there is clinically carotid bruit heard. Carotid intervention should be considered in coronary artery cabbage bypass if the patient is having 50 to 99 carotid stenosis, if the history of stroke in the preceding 6 months, and carotid endarterectomy should be considered much better than stenting for coronary bypass patients. patients going for CABG and he's having asymptomatic stenosis, if the unilateral 70 to 99%, intervention is not recommended for the prevention of stroke, and this is 3B. If the patient's having bilateral 70 to 99, carotid intervention may be considered, and if it is 70 to 99 stenosis with contralateral occlusion, carotid intervention may be considered again. This is level 2B. Okay, the choice between carotid endarterectomy and CAS in asymptomatic patients who have carotid disease and going for CABG should be based individually on the urgency, how soon should I go for surgery, the choice of antiplatelet therapy the cardiothoracic surgeon is preparing, individual patient characteristic, and the symptom status, and the local experience, of course. Okay, for non-cardiac surgery, patients undergoing elective non-cardiac surgery, major, of course, with a history of a stroke, should undergo carotid artery imaging, should have imaging. And if the imaging proved to be 50 to 99%, revascularization before elective surgery is recommended. But routine carotid imaging in asymptomatic patients is not recommended. And prophylactic carotid intervention are not recommended in patients with asymptomatic carotid stenosis with major non-cardiac, non-vascular procedure. Thank you very much. I hope I stick to my time. So we still now have time for to have some questions. I can stop my sharing now. Okay, we'll go first to our panelists to have some comments or questions. We'll start with Dr. Ala Ahmed in Jeddah. Dr. Ala.
Thank you very much, Professor Salah, and thank you, Professor Martin, for this elegant presentation. Really, I would like to start by asking a question to Professor Martin regarding some things. First of all, we are talking about the CREST-2 registry. And in this registry, we found that the carotid artery stenting and the carotid endarterectomy may have a double increase in the stroke rate. Regarding your experience, Professor Martin, what is the best choice you will give to your patients if he is complaining of asymptomatic carotid stenosis? What you will give him? What is the option you will give?
Okay, first we have to clarify there is a CREST randomized trial comparing stenting and surgery, and they had a combined endpoint including myocardial infarction. And then there was, if you have all three endpoints, no difference. If you have the endpoint stroke and death, then surgery was a little better. These were mainly symptomatic patients and also asymptomatic patients to make the number large enough, because all these studies, for some reason, they had recruiting problems. And the CREST-2 registry is only about stenting. So this I want to make clear. And it shows both these American US trials and registry show that stenting, for some reason, could not reach the same safety as surgery for treating carotid stenosis. And I think the Endovascular Society by now accept this, but they still develop better protection systems and better indications and new systems. As I showed you, the TCAR system is a little improved, at least in these registry studies, which they published like Peter Schneider and Mark Sherman. So in our patients, we have to, but just for legal reasons, we have to, in the case of symptomatic, let's start with symptomatic first. If you see a symptomatic patient, we have seen in the guideline 14 days is the longest period until the treatment should begin. Actually, we try to do it between 2 or 3 days, and we do not hesitate. So we always involve a neurologist, which is also in the German guidelines very important. It does not appear in the international guidelines, but we do the indication together with the neurologist, and the patient is informed about the possibility of stenting as an alternative to surgery. And if he prefers stenting, and if we tell him the data from the studies, but if we say in our hospital, we need some transparency to show how good is the result of stenting, how good is the result of surgery. If it's comparable, which is most of the hospitals the case, then we let the patient decide also. But I think it's fair to give the patient a chance to talk to a vascular surgeon, not only to the interventionalist, and say you can avoid surgery by using a stent. But there's a little but the stenting might be dangerous for you. So this is what the patient sometimes is not told. It depends where the patient is. There are large endovascular centers and also cardiologist centers, and they don't even have a vascular surgery department in their hospital. So in these hospitals, of course, there's some bias. This is an unsolved question, but from the mere point of evidence-based medicine, we have to tell the patient stenting is in any case not better than surgery, even in some cases more risky. And if you talk to a patient like that, most of the patients will agree to surgery. For the asymptomatic, it's more difficult because we still need this ACS2 study by Alison Halliday. And as far as I know, the stroke rate in general is very low in both cases. So in these cases, it might be that asymptomatic patients could easier be stented than the symptomatic. And this is a new perspective, because the most interventionalists treat, of course, the symptomatic patients, which makes the majority of the cases. And thirdly, to just give you a complete answer, as Dr. Mahmoud showed very nicely in the recommendations, if you do surgery for incoming stroke or for like after lysis or these special indications, most of the cases the surgery is the safer option, because you have all the possibilities. If you do the clamping with shunting or then the patient is very safe. In the moment where the carotid is clamped, the patient is very safe. But if you introduce, I know they're very skilled endovascular guys, if you introduce the protection device and you go with a wire through and pre-dilatation and stenting, you really need good filters. And most investigators have shown that there's always some little plug in the particles can be found in the filter. So it means the microembolization risk might be higher in some cases of stenting, and it can be avoided for surgery. So this is a still unsolved question, but we try to give the patient a good information and really try to convince them that surgery is in most cases very good, if not the better option.
Thank you very much, Dr. Martin. Dr. Ala, you have another comment? Or?
Yes, I have another question regarding, it is a repetitive question, I think. It is regarding the timing of the carotid surgery. I know that the answer was in the post presentation, but I need answer from both of you, Dr. Salah, from Professor Martin and you, regarding the timing. Would you go for early carotid endarterectomy? Will you go for early carotid stenting for the patient, or you prefer to wait for the 2 weeks as we usually do before?
Well, the recommendation, as I mentioned, it's as early as possible, but within 14 days. So I think 14 days of what? 14 days of the symptoms. The patient is having either minor stroke or having TIAs, and you want to put him for carotid endarterectomy. Once the patient is fit, I think you should take him to the OR. I don't know what's the opinion of Dr. Martin about this.
I completely agree. Sometimes we have the problem that the patient is seen by a primary care physician and then by a neurologist, and then it takes some time until he comes to the vascular department. And 14 days is maximum time period, because after that time period, and these are many publications by Ross Naylor, the risk of stroke increases dramatically, that the patient might develop a stroke. Also, what is very important, as soon as the patient is symptomatic, it should be immediately started with aspirin And if it's really great symptomatic or a minor stroke, there should be even a dual platelet inhibition to the time point of surgery. So in some patients, we have to do surgery under dual platelet inhibition, which is not a reason to switch to stenting. I mean, if somebody is stented, he is always loaded with clopidogrel in addition to aspirin. But if a patient has a symptomatic carotid stenosis and is in a neurological department, sometimes they have their own guidelines to do a dual platelet anti-inhibition, and then we have to decide, can we do surgery under dual platelet inhibition? But the time period discussion is much more exciting if somebody has a stroke, a manifest stroke, as we have heard, and it's like a 5 centimeter large area involved, and the patient is stable. What is a good timing for stroke, surgery after stroke? And I think this is not really decided. Most people say at least wait 2 or 3 days and see whether the neurology is really stable and not too early. So if you do like 1 day after minor stroke, it could be a worsening of the neurological symptoms. So what we do in these cases with the neurologists, we have an agreement that they like to keep them for 2 or 3 days in the stroke unit anyway before they give them away. This has also some financial reasons in Germany, but anyway, it makes sense to wait 2 or 3 days. But this is in close discussion with the neurologist. And I think, Mahmoud, the guideline recommendations in this issue are not so clear, and they're changing. And there are so many good studies and registries from Sweden, for instance. They found early surgery is very good, and other registries say it's very dangerous. And early stenting, especially, is very dangerous.
Okay.
Thank you very much, Dr. Martin. Can we go to Dr. Rafat, our second panelist? I'm sure that he's having some comments and questions. I can see that.
Thank you so much, Dr. Mahmoud, Dr. Martin, for these very lovely and informative presentations. Personally, I have enjoyed them. I hope the rest of the audience did. So yes, I do have some comments, and I'd like to get more insights from you. So in the old times, we used to hear something called the lesion characteristics. Is it plaque? Is it a circumferential plaque? Is it a soft plaque, a hard plaque, an ulcer? All these lovely characteristics that we used to be told. In your practice, Dr. Mahmoud, do you believe that the classification of lesion characteristics still play a role on the decision of what type and what to do for which patient, or no?
Well, about the characteristics of the lesion, of course it plays a role, but I think that the percentage of the stenosis plays more important role. Of course, we have sometimes the duplex is giving you some characteristics about soft plaque, ulcerated plaque, and this definitely, some plaques are very nasty and push you more to the toward intervention. I want to hear also from Dr. Martin his opinion about this point.
I think the the plaque characteristic becomes important in the asymptomatic plaque. If there's a plaque with a hemorrhage, you can see in the MR like a vulnerable plaque or unstable plaque, soft plaque with a small cap or hemorrhage. This is considered to be morphology which should rather be removed, instead of if it's a stable calcified plaque which doesn't change much, then you can be more reluctant with the indication. And our German guideline, I think also in the European, they have some recommendations about plaque morphology, and this is a big discussion in all medical congresses. You need a good duplex imaging or even MRI transectional view of the plaque. But if you see plaque hemorrhage, I would not hesitate to do surgery in 60 to 70% stenosis in asymptomatic patients. So I think it's more important in the asymptomatic than in the symptomatic, because if the patient is symptomatic, he needs surgery anyway, no matter whether the plaque is a rather soft or hard plaque. So in our hospital, my colleagues or the trainees, they are told at least to describe the OR report. Was it a soft plaque or hard plaque, and was it ulcerated plaque, and did you see any hemorrhage? So I want to know about this and to like to the quality of the indication. It's my opinion.
Thank you very much, Dr. Martin. We also have some comments from Dr. Wael Sha'lan about this, that he's definitely encouraging that the characteristics of the plaque is more important is in asymptomatic, as you mentioned. And as I said, also some very bad characteristics in the ultrasound push you more to intervention. So I think we agree for this. I don't know, Dr. Rafat, you satisfied with the answer or not?
Yes, this is as satisfactory as we can reach for the time being. I totally agree with the great opinions that were said by you and by Dr. Martin. If I may also just put another question, just for the simple practice that we all go through, would you rely more on carotid duplex, or would you rely more on a CT carotid angiography?
Well, this is a difficult question. You have to have very good ultrasonographer to depend on this, but I think the ultrasound can give you, if you trust your ultrasonographer, it can give you very good details. And in some cases we operate without CT, but the routine is to go for CT if you can. Dr. Martin?
Yes, I agree. I think the degree of stenosis and the classification of the stenosis should be done by duplex ultrasound. This is also the German guideline recommendation. But the additional information you can get by an MRI, so we prefer MRI angiogram, is to have more information about the intracranial architecture and also to see whether there is a common carotid or downward stenosis, which you can also exclude by a good duplex. If you see the waveform, the triphasic waveform, and you have no post-stenotic symbol, you can exclude proximal stenosis, but it's difficult to judge the intracranial situation from extracranial ultrasound. So actually the indication is made by the duplex, but the safety and the complete information about the vascular anatomy is done by an additional CTA or MRI. So we do not hesitate to do this. However, it's also possible to have a good duplex, just a native CT scan to exclude any bleeding or tumor or any disease, to do it like that. It depends on the clinical situation a little bit. But if in doubt, we would do an additional angiogram with MRI or CTA.
If I may just add one last comment, and I have one last question that I'll keep to the end if you allow me. Again, regarding the same question about duplex or CT. If you take a decision that the patient would benefit more from a carotid artery stenting, would you at that time go for a CT at least to view the arch, or an MRI to view the aortic arch to get further data, or you'll still be satisfied with the duplex and go for a routine angiography while you're doing the procedure?
Well, I think, Mahmoud, you first.
No problem. Well, I guess if you decided to go for carotid artery stenting, you should have CT or MRI to know about the arch, your way to reach there. So it will be because maybe after you see this MRI, you change your mind. Okay, maybe you will not go for stenting. So I think you should do this. Dr. Martin will give us his feedback.
It's the same comment. Sometimes patients have a pacemaker and the MRI is not so easy. Then you need a CT scan and some radiation. Most of the modern carotid devices, they can go around any curve, but the type 3 aortic arch, where they really have to do an S-curve all around, it might be much more complicated. I think you should be prepared that there might be some difficulty, because the most dangerous part of the carotid stenting is not the stenting, but it's putting the sheath into the common carotid artery. To get there, this is a tricky one, a tricky part of this. So it's always better to have this information.
Okay. Dr. Rafat, you have any other comments or questions?
Thank you. I have a biased question that I prefer to keep it to the end and give the chance to the rest of the audience.
Okay, we have some questions. Actually, we have a question from Dr. Osama Lotfi about the best timing. I think we already answered this, the best timing to perform endarterectomy following minor stroke, and we agreed that 14 days is the very good timing, and the earliest the better. We have again some comments from Dr. Wael Sha'lan about the plaque characteristics, and that the duplex in most cases enough, but CT has certain indications. Of course, we completely agree. I have a question for Dr. Martin. What about the proximal lesions, the innominate lesion, the beginning of the proximal common carotid lesions? What would you recommend for such cases?
Yeah, the answer is depends. Is it high grade? Is it heavily calcified? Is it necessary to treat it? If it's necessary to treat it, let's say because it's high grade and there is a danger of occlusion or embolic disease, there are two ways to do it. You can, of course, also do it retrograde. You're probably talking about that you do from transcarotid retrograde approach in some cases, because you can do embolic protection by clamping. Doing it transaortic is a little difficult in some cases because you cannot routinely use a protection system, and this is really not very common, but in these cases it should be really well planned. So what's your opinion about this, Dr. Mahmoud?
Well, I agree, because you know, it's whatever you can do endovascular for such cases definitely will be more easier than thoracotomy, for example. You know.
Of course, yeah.
So I completely agree. I have another question about for bilateral significant stenosis and patient will have CABG. Do we do carotid endarterectomy for both sides or unilateral lesion?
So you want me to, my opinion?
Yeah.
It's of course not a standard situation, but usually it's recommended to do only the left carotid. That means where the dominant hemisphere is, it should be enough to go for one, because the stroke rates in combined surgery are much higher than in isolated carotid endarterectomy, no matter whether you use off pump or hypothermia, whether you do it first or after. So I think it's not necessarily to do both in one session. So if you do one carotid, and probably if both are the same degree, then we would do the left one, because the left hemisphere is dominant with the center of speech, and so we would do the left side first. Maybe later on staged the second one. There's a very good paper by Ross Naylor about the complete evidence for staged versus non-staged and triple stage procedures in combined surgery. It's very nice to read this, because the evidence is completely a lot of disparity. So some results are good, some are not good. It's just the number too small to do this on an evidence-based decision. So I think we would go for the left side and talk to the cardiac surgeon that we do. So we would recommend to do first the carotid and in the same procedure the coronary, and not put the pump in and put the blood pressure down, except if it's hypothermia, then it might be protective. So the cardiac surgeons, they don't even agree among themselves how to properly do it. There are very famous German centers like Professor Haberich and Professor Mohr, and they told me they've never seen a problem, but in a statistical if we do the complete registry data from Germany, we have many centers doing combined surgery. They become very reluctant. Actually, the cardiac surgeons don't really like to do combined surgery anymore, so they really do this only if they have to.
Okay, but you prefer, if you have bilateral carotid, you do at least one, which is the left, and this is before the CABG.
Well, in the same, it can be in the same session.
Can be the same session.
We start with the carotid and then the CABG.
Yeah, I know that.
This is
but
one
you don't
option.
like
I know that there are different ways to do it, but this seems the best way to do it because you solve the problem with the carotid. Meanwhile, the cannulas can be put in and the vein has been harvested. This can be done simultaneously.
Okay. I guess we don't have questions from the audience. So, Dr. Ala, do you have any more question or comment? Your mic is mute, Dr. Ala.
Sorry. I have another question regarding the patients with the pre-occlusive disease of the carotid artery.
Come again, please.
Nearly occlusive, yeah, very good question, yeah.
Yes, nearly occlusive. Is there any criteria by the duplex ultrasound, like the diameter of the internal carotid, like the flow? I mean, how can we do it or not to do it? Because when we see total occlusion or near total occlusion, we decide not to proceed except if there is embolization. Is this the update also?
Can I first?
Yes, please, Dr. Martin.
So the European guidelines recommended to not necessarily treat near occlusion, but there is a recent paper out showing that these patients can have a benefit if they're still treated. But what you need in these cases, in my opinion, is an arterial angiogram of the selective carotid angiogram to really see how much perfusion is, and is it really still patent after the occluded segment, or is it a string sign that goes into the intracranial range, because then it doesn't make sense to put a stent in, and surgery can be a catastrophic result. It ends with ligation sometimes. It's the problem is, if there are only a few milliliters of blood going through, the hemodynamic effect of this nearly occlusion is probably very little. So that means if it thromboses, it doesn't make much effect. But on the other hand, actually you should really make sure that it is a near occlusion. I think duplex can sometimes show a rest of minimal flow, and in these cases, when in doubt, we do not hesitate to make a transfemoral selective arterial angiogram and be ready for stenting if it's an indication or not. We talk to the patient. In most of the cases, we do not do anything, just make a clear angiogram and see it's not a problem, not a clinical problem. Let's say it's too late.
Okay.
What's your opinion, Mahmoud? How do you treat those? It's very rare. I mean, it's not very often.
Dr. Salah?
Yes, Dr. Ala, go on.
Okay, thank you. This is, I will give time for the others.
Okay, I have a question. Is it indicated to do angioplasty of middle cerebral artery in the same time of internal carotid artery? Is it safe? Dr. Martin?
I would say no, because if it's asymptomatic, there is a recommendation not to treat it at all. And if it's symptomatic, most of the cases are done as an extracranial stenting combined with intracranial procedure by a neuroradiologist. But to treat an asymptomatic stenosis of the middle cerebral artery, it's actually not recommended in the guidelines for this specific disease. So it really depends on the clinical situation. If you decide to do angioplasty of the middle cerebral artery, then you can do on the way back stenting of the extracranial part. This is what usually done. So you don't do surgery and intracranial endovascular. This combination is not very common.
Okay.
But what can happen if you do extracranial surgery, you make an angiogram and then you find by accident this stenosis. That's why we like to have this MR angiogram or CT angiogram before, so we're not surprised to see this.
Yeah. Okay, Dr. Rafat, you have a question?
Okay, thank you again. So, as I said, it's a bit of a biased question. Yes. So I'm a surgeon, so I'll always be biased towards surgeons. Would you say, Dr. Martin, in your setting, or Dr. Mahmoud, from your vast experience, the procedure of carotid artery stenting and the decision to go for it would be better taken by a vascular surgeon, an interventional radiologist, or an interventional cardiologist? Because over here in the Middle East, this procedure is done by all these three specialties, and there is always a bit of a competition around who does it and who says should be done or not.
Okay, before I give the mic to Martin, I would like to have a comment, because of course our dear colleagues, the interventional radiologists and some of the cardiologists are doing carotid and the peripheral. I guess the best one to treat the patient is the vascular surgeon, because you are the vascular surgeon. You have all the options in your hand. You have the surgery, you have the endovascular. If you are surgeon but you are not working endovascular, you will definitely give the patient only half of the best solution. If you are an interventional radiology and you are not surgeon, so you will also give the patient from your own point of view that the only solution for him is endovascular. But if you are vascular surgeon working as endovascular also, you have all the options and many procedures you can do both in the same patient. So I'm not saying that we should be the only one to do this, but I'm sure saying that we are better to have all the options in our hands, so this gives the patient a much better chance. I don't know, what's the opinion of Martin?
There's nothing to add. I agree completely. This is our credo in vascular surgery. We are the specialists for vascular disease, and the cardiologists, actually, they do a little bit also stenting in the carotid and in the periphery, but it's actually our main field of medicine. So it's a little bit different in each country, but we should be strong and have this possibility and these tools in our hands also. That's my opinion.
Thank you very much, Martin. Any more questions, Dr. Rafat or Dr. Ala?
I'm happy with that. Thank you. Yes, vascular surgeons are the best. Thank you.
Thank you very much, Dr. Mahmoud, and thank you, Professor Martin. It is a very elegant presentation and a very fruitful discussion. Thank you for everything. Thank you.
Thank you very much. I would like to thank all the audience because we cannot do this without our dear audience, and very beneficial comments from our great audience, and hopefully we can meet again in another session. Thank you for the Saudi German Hospital for arranging this, and hopefully we can meet again. Thank you very much, and have a good night.
Thank you.
Thank you.